how do you see a patient differently, whether they're transplant or not transplant related?
So it's really important to know who you're dealing with. All right. So a transplant patient versus your neighbor who's totally healthy, you'll think about them completely differently. So for instance, if your neighbor comes by and says, I've had a cough for a week, and I'm feeling tired, and I'm having these low-grade fevers, odds are they got a cold. It's not a big deal. You tell them, drink a lot, take a couple Tylenol, see how it goes, it'll probably go away. Because colds can sometimes last a week or two or even 3 weeks before someone's completely back on their feet. And so that would be the response there. On the other hand, a transplant patient's a very different person. You usually have a long-term relationship with them, so you know them well. So if someone you know who never complains about anything comes and says, I got a cough, I don't feel well, something's wrong, ding, it brings up a whole slew of different things and brings up a different reaction from a transplant doctor. Just because it's the person you know and they have a different set of risk factors. So that same person may have a pneumonia, that same person may have a cancer in their lungs, totally different response, or at least there should be a totally different response.
And so if they get the advice of treating it like the typical cold, and if it doesn't improve, come back to it, as you mentioned before we didn't record it, would you repeat that part of it?
So it's okay if that same person comes in and your doctor says, well, it's probably a cold, but odds are it probably is a cold. But unlike your neighbor who says, yeah, go away, this person, there should be some sort of backup plan, all right, saying it's probably cold, take some Tylenol, drink a lot of fluids, but if it gets worse or doesn't get better, you need to call me and we will do X, whatever X might be. So in other words, someone needs to stay on top of it, and if someone thinks that there really is a problem, don't wait, act upon it now. So this is transplant or organ transplant is a long-term relationship between a doctor or team and a patient. And over a bunch of years, they generally get to know each other pretty well. But this is a backwards and forwards relationship, so patients know themselves. I would say essentially 95% of patients who have come to me with PTLD, they knew they had a problem. Okay? It's not a shock that they were found to have this. They knew there was a problem, they just didn't know what it was. And so if you know your body and you know yourself and something's not right, namely if you say, yeah, I got a cough, my kid had a cough, I probably got a cold, that's fine. You don't need to go running to the doctor, okay? On the other hand, if it doesn't go away and you say, this isn't right, you need to trust your instinct and go to your doctor who should also trust your instinct and negotiate a plan to figure it out.
The patient that comes to you from the transplant team with that conviction there's something wrong, what do you do? I mean, you're going to interview them certainly, but what kind of testing do you do given what you said it's hard to tell what symptoms really aren't obvious? What kind of testing do you do to find the root cause?
Well, my job isn't that hard. Namely, patients are essentially seen by the transplant team, and so by the time they get to me, the transplant team's red flags are flying everywhere. So these patients, there's a real obvious problem going on. So if I'm trying to work up a lymphoma like PTLD, it's very simple, general physical exam, but CAT scans and MRIs are the real thing you want, because these are generally enlarged lymph nodes or tumors, and in general, yes, sometimes they occur on your neck and you can feel it, but in general they're deep inside. Patients don't know they're there. They might have some vague pain, but they really don't know what's causing it. And so with the CAT scan, you'll often see an enlarged lymph node or some sort of tumor someplace, and you go, there's the problem. And then oftentimes you want to get a biopsy to prove what that problem is. Because an enlarged lymph node could be infection, it could be cancer, but even there you don't know what type of cancer usually.
And we certainly have an advantage here at Penn Medicine, given the network of specialists like yourselves who see not only cancer patients in general, but deal with a good number of post-transplant cancers and can treat and realize the differences to look for there. What other things within that contrasting population do you look for? In other words, versus the patient who's sent to you by a local doctor versus a transplant patient?
So the same person, shall we say, coming from a transplant team, they're different from a person coming, let's say, from your local doctor to see me. Once again, just like your neighbor, All right, someone coming from a local oncologist, you figure they have a cancer that's not your neighbor anymore, but it's still not a transplant patient because of the medications they're on. Certain cancers, such as skin cancer and lymphomas, are at much higher risk. Much higher. So they have to be first on your list. But infections, the drugs cause problems. And so there's infection risk. So is that spot in your lung a tumor? Or is that spot in your lung some sort of odd fungal pneumonia that just looks like a tumor? So being a transplant patient, the list of things that can occur are different from a regular cancer patient, and it's different from your neighbor. So you got to sort of see who's walking in your door and what risks, what issues are you concerned about, what issues might happen.